I'm Jonah Comstock, Editor-in-Chief of pharmaphorum. We're at day 3 of ASCO, and I'm joined by Dr. Fred Saad from the University of Montreal. You were one of the investigators on a recent trial of Novartis's Pluvicto.
Right.
Tell me a little bit about the trial and what you've learned.
Right. So the trial is PSMA addition. So this is an attempt to do better than the best standard of care we have for hormone-sensitive metastatic prostate cancer, which is ADT and ARPI. And so patients were randomized to getting ADT, ARPI with or without Pluvicto or lutetium PSMA. And what the primary analysis showed is that we were able to statistically significantly improve radiographic progression-free survival. And this was presented and is in the process of being published. So there was a 28% reduction in the risk of rPFS in patients who got Pluvicto added to this very best standard of care of ADT and ARPI. What I'm presenting here is some subgroup analysis of how patients did if they had high volume or low volume disease, or if they had de novo metastatic disease versus recurrent metastatic hormone-sensitive prostate cancer.
So what's the finding there?
Right. So what we found is that when we look at the primary endpoint of radiographic progression-free survival, regardless of whether you are low volume or high volume, recurrent or de novo metastatic, the benefit was very much the same. So very close to the 0.72 in all 4 subgroups. So this is very reassuring that patients, regardless of how they come in, are benefiting to the same degree for the primary endpoint. Then we looked at time to PSA progression, which is often the first signal that patients are starting to fail. And there we see, again, very excellent results across the 4. Surprisingly, the patients with the low volume had the best hazard ratio of 0.29. So we're seeing across the board that we're able to significantly delay PSA progression. We're able to delay metastatic castration-resistant disease in all 4 groups. It's still early follow-up for the low volume because these patients don't progress as quickly, and we've only got about a 2-year follow-up at the time of the cutoff for the data that I'm presenting here. And what we're seeing that's also reassuring is that in terms of quality of life, we're not seeing differences depending on whether they were low volume or high volume, very much in line with the primary results of patient-reported outcomes. And then the other reassuring point is that in terms of adverse events, we're not seeing worse adverse events in these low-volume patients where we might worry about maybe giving them too much drug because they're low volume. We're actually seeing very similar adverse events, whether it's grade 3 to 5, serious adverse events, dry mouth, or renal toxicity. So encouraging results in terms of efficacy and reassuring results in terms of safety.
Now, Pluvicto is a radiotherapeutic, right?
That's right. So radioligand therapy, so it's an intravenous drug that's linked to PSMA. So what you see is where the drug is going to go to. So this is a new generation of therapy that's very exciting for patients.
Right. Traditional radiotherapy is already quite often used in this metastatic prostate cancer setting, but this is something new, something about
right. Well, conventional radiotherapy is not going to be very useful for patients who have metastatic disease because these patients have systemic disease. So conventional radiation therapy to the prostate is extremely used and very effective in localized disease. But in metastatic disease, obviously treating the prostate could be important, but the most important is getting to all, the cancer that's everywhere. And there we need hormonally based therapies. Sometimes we'll combine it with chemotherapy. And here in this patient population, we're showing that lutetium can be a form of triplet therapy that can be very interesting and well tolerated for patients.
I know that the radioligand therapies, it's a fairly new class of drug, and there's only a handful that are already approved, right? This being one of them.
Well, this is lutetium. The one that we use here is the only one that's really approved as radioligand therapy. The only other one which has a different mechanism of action is radium-223, which really only targets the bone environment. This one targets all the cancers. There are others in the pipeline being studied, actinium-based and others.
Bayer has one, right?
That's right, but that's only in phase 1. Bayer, Xofigo is the radium-223.
Oh, that's one you're
That's right,
about, yeah.
But that's really only specific for bone metastasis. It won't go anywhere else outside of the bone. So this is why Xofigo is an extremely effective and useful agent. But when we want to tackle all the cancers, wherever it is, lymph nodes, liver, bone, we need to target the cancer cells identified by PSMA imaging and link it with a radiopharmaceutical that gets to the cancer cells themselves.
So what is the kind of practical outcome of a study like this? And what does this data tell oncologists that they didn't know before? How does it help them make decisions?
Right. So Pluvicto is already approved, but for castration-resistant disease, mainly after docetaxel. That's the main utility around the world and where the approval is most common. And now we're shifting to the hormone-sensitive setting. So this is at the beginning where we might have the biggest impact in getting patients into deep long-term remissions, maybe even cure some patients. So this is where we have an opportunity when they're newly diagnosed with metastatic disease that hasn't become resistant to hormonal therapy yet, where we might have the biggest impact. So every time we've looked earlier in selected patients seems to be more effective than waiting for them to develop resistance.
Great. Stepping back sort of more broadly, what have you seen or heard at the show so far that's been interesting to you? What are the trends you're seeing, hearing about?
Right. So there's been a lot of really great data presented here at ASCO. I think one of the most exciting areas is what we can do for patients that have HRR mutations. And this was presented yesterday with TALAPRO-3, looking at Talzopper combined with enzalutamide in patients with mutations in the hormone-sensitive setting. And those patients did extremely well, especially the BRCA mutated, but even the mutated patients without BRCA were doing extremely well in terms of delaying progression of the disease and getting really excellent responses, both in terms of measurable disease and in terms of PSA responses. So really exciting for patients that unfortunately have these mutations that reduce their survivals. So we have something now very specific for those patients. And it's the second trial showing that PARP inhibitors can be useful before they become castration resistant.
Great. Well, thank you so much for talking with me.
Thanks.
I appreciate learning about this trial.
Excellent. Thank you very much. Take care.